My name is Dr. Tyler Tolbert,
And I'm Dr. Soren Poppy,
and you're listening to the Fix Podcast.
your source for all things implant dentistry.
Okay, great. So, yeah, I think those are invaluable topics that, photography, proper records and everything, they go a super long way for people who are trying to manage their complications over time and just see how their cases progress over time. I know that a lot of people are super interested in custom implants and subperiosteals, and I know that, you're a big front leader in the custom implants, at least the new age ones, right? I was at course in Portugal when Picos came and showed all of his mandibular subperiosteal implants that he's done over the past, 30 years and the follow-ups of those and how wonderful they are. And I think that, seeing a lot of these zygo cases and stuff, it's really important to bring in subperiosteals in the maxilla because it does offer another, I guess you could say lifespan for patients who I feel like there's the full arch lifespan, right? And then if we can eliminate that zygo lifespan and instead have a subperiosteal lifespan, and then maybe zygos in the future, or if you have, all on fours that turned into zygos, and all of a sudden those zygomatics are failing, I feel like a lot of patients are in a situation where they're stuck with a really shitty denture then for the rest of their life. So, incorporating subperiosteals then, go ahead.
Yeah, this is the reality, man. There are countless patients that had failed quad zygos that there are on obturator prosthesis at this moment and that nobody knows about this reality. Mm-hmm. This is some what is under the iceberg, because nowadays the industry is pushing zygos with such power that doctors almost feel like they are surgical inept if they don't do quads every day. And the reality is that the need for quad or for a sub is less than 1% of the cases. That's the first thing we have to keep in mind, because with all the other techniques, you can go to 99% of those cases, which is the overwhelming majority of the full arch population. The quad zygo problem, it's not a problem of the implant, it's not a problem of techniques, it's not a problem of the doctor that places them. It's a problem of anatomy. We have the sinus in the middle, and we need to create these big slots to place this short implant, because the zygo is a short implant. The implantable part of the zygo is quite small. It's 10, 11, 13 millimeters only, but it has a very big arm, but the implant is actually a short one. And the destruction that is necessary to do a quad is something that is so big and so irreversible that it is even difficult to do a sub after you lose a quad. Is difficult, the destruction that is left, the big oral sinus communication that you have, the zygoma that gets destroyed, it's very difficult to approach a case like this. And I think that we should consider the custom superiosteal implants, because I said the other day this on social media, and the majority of people understood what I was saying, but there is always a small percentage that wants to test the words, but this is true. The subperiosteal surgery, guys, is a minimally invasive surgery, because we have to think the minimally invasive concept always depends on the expected outcome. You understand what I'm saying? We cannot expect to solve a super atrophic case with a single implant. It's not going to solve the case, right? So we need to understand what is on the table. A super atrophic case either goes for a quad zygo or for a superiosteal implant. So for the two options that are on the table, when I say that this is the minimally invasive one, is compared with the other solution that achieves the same result. So in this sense, yes, it's a minimally invasive solution compared with the quad, because the quad, we know the destruction that is required to place the implants. So yes, I do believe that is something very promising. The fact that is customized nowadays without having to open a flap like it was on the old days that were two surgeries were necessary, one just for the impression of the bone and then another one for the placement. Now we don't need to do that first one. We use the CBCT scan. It's a surgery that takes about 1 hour. Most of my surgeries actually, and you know this, you have seen this, take local anesthesia only. And we are absolutely positive that this patient is going to have fixed teeth today. It's not something that we aspire to, it's a certainty in this approach. So when I think about, the pros and the cons, the only cons that I see is that first, you need a few weeks to produce the implant. You cannot just appear in the office and boom and do it. No, you need to take the scan, you need to design the implant, to print it and all these things. And the price. It's more expensive than buying a couple of zygomatic implants. But besides these two things, I think the pros are way more than the cons, and that's why when I started with this kind of technology, I said to myself, okay, now I have, I'm on a crossroads. Do I continue with the Zygos, or do I go into this journey, pioneering approach, and try to maybe change a little bit the way these very complicated cases are going to be done in the future? And, we took a leap of faith, but it was not real faith, I mean, we studied all the concepts. I read the Linko books. I spoke with people that did the old ones back in the days. I spoke with Mike Picos as well. His follow-ups are amazing on the other ones. And I think this new technology has evolved so much, and there's so many nuances that make this work better than the other ones, that it will be, having this available here, for example, in Portugal, having this available and not using would be an heresy, I mean, why should I destroy the mid face when I can keep all the remaining bone and still do immediate loading?
So that's something that I want to speak to there, because we're talking about the minimally invasive concept as it relates to
the outcome.
Quad zygo.
Yeah.
Right. Of course, yes.
Yeah.
In comparing zygos versus customized implants, you made the point that with the way that zygos are being done today, it can be very difficult to then rehab them with a customized implant afterward. Aren't as versed in zygos or customized, right? Is that right now what is a very popular modality with zygomatic placement, whereas traditionally it used to be an intrasinus approach that would start transpalatally, very palatal to where we are normally placing traditional implants, and then it would transverse the sinus exclusively, and then of course the superior border of the sinus is going to be the inferior aspect of the zygo. And so there's not as much there's not necessarily any destruction to the sort of outer maxillary wall that forms the sinus. But now what we're seeing a lot of is this extra sinus approach. So they're doing slot preparation along the wall of the sinus, and this has a lot to do with the classification of the case, right? You can talk about different cases.
Yeah, but actually, Tyler, the Branemark approach, the first one, was the more conservative, It was way more conservative.
In this sense, right?
It was more dangerous.
This is counterintuitive.
Yeah, it was more dangerous, and the palatal exit, the prosthetic exit, was worse.
Terrible.
Much
worse.
But But if I was a patient back in those days, and I had the option to do the external approach or the internal approach with Branemark, I would prefer the internal approach in my mouth, because it's way more conservative.
Right. It is. It goes through a space that's already empty, and you still have the bony architecture of the maxilla. So that, I think that's kind of this sort of counterintuitive nuance to what we consider minimally invasive, is the way we're doing the extra sinus approach is actually more destructive to bony architecture that could be used for a customized implant. So I think that's a very interesting nuance that you bring up for sure. Yeah, I love to do everything I can to preserve, even in transsinus, for example. If I have a clear sinus, I will not open the wall, I will keep the wall of the sinus because
intact.
You're going to create a window there.
Because when you create a window, you are opening the possibility of having a oral sinus communication. You are opening the possibility of the failure of the graft. And once that happens, it's very difficult to create a new sinus window. And, this is the cascade of destruction, the ladder of destruction. You start destroying, and the correction is always a bit more destructive than what it already was. And things start to escalate very quickly and start to go to the point of no return. And this is what I really keep in mind at all the times when I do a treatment plan. And I would advise anyone to do the same, is to see how irreversible is the stuff that you are doing today, or is there any alternative that is more reversible for this patient? Because remember, your implants will not last until the patient dies. 2/3 are there, 1/3 is lost after 15 years. So,
Bernardo, what are the
for those that aren't as... Sorry, I just wanted to make sure. So for those that aren't as familiar with the concept of customized implants versus, like a subperiosteal design. So can we talk about, the design of these customized implants as it relates to the anatomy, as it uses the bony architecture? How is it anchored? How is that anchorage working differently than a zygo? How does that then translate to a prosthetic success as well?
So the anchorage point of the custom implants is as the same exact basis of the fractures of the maxilla. The Le-4-1 principles that we know for more than 100 years. This is really not something new. We know that the strongest parts that we have is the three main buttresses, right? The zygomatic buttress, the piriform, and the pterygoid buttress is the three main buttresses that we have on the mid face, and that's exactly where this implant is anchored. We have two very long implants here on the zygo. They are 22 millimeter implants, micro implants. They are narrower. We have a bunch of micro implants here all along the canine pillar, and we have one on the palatal side. But to most of the implant is anchored. The most important part is the zygomatic anchorage and the piriform buttress anchorage. This is what keeps the implant so solid that you see this actually in a real patient, or even if you try this on a model, you screw all the screws and you try to move, you try to bend it, and it is rock solid. You can't move this. The micro movement here is zero, contrarily to the zygomatic implants, which often
the tuning fork.
They don't have a micro, they have a macro. Sometimes right there at the moment of the surgery, because the arm is so long and it's such a big area unsupported that the implant actually bends. You can see it, and actually there was a paper published that I just put on the WhatsApp group a few weeks ago, a clinical lab study comparing the bending of the zygo depending on the length and the bending of the custom superiosteal implant. And the bending of the zygo often goes to past the threshold. The bending, the deformation on the custom implant is always within the acceptable range, so it doesn't fracture. So it's a different approach.
Can you talk about the process for workflow as far as records, fabrication, and then like surgical placement with the prosthetic?
Yeah, it's super simple from a doctor's point of view. You have the CT scan of your patient, you just send it to the lab, they will design it. You either change something that you feel like it should be a little different. I always make a change here or there, I have done so many that I know from experience that I prefer to be like this or like that, but they are minor, to be honest, minor stuff. And then they will send it to you, and you just book the surgery. From a doctor's perspective, it is the easiest thing on the world.
What about I think the biggest question that we're gonna get, and you're talking about all these pros with the customized implants, and people are gonna ask, well, how do I get them, right? So what's the timeline looking like in the United States? Can you give us some? My understanding is that they're not approved quite yet, but I think for the last year we've been told they're coming. So what do you have any insider info about?
You have to let me make a disclaimer, because I believe that most of the world thinks I have something to do with the company, and I don't. I have 0 shares on the company. I wish I had. But you should. But I don't work for the company. I have no royalties in anything, so I really don't know. And I know that this process with the FDA is taking a bit too long, and it should have been approved by now, a long time ago. But as far as I know, and this is unofficial information, it's going to be very soon. I cannot compromise on anything, because again, they are telling it's very close for 2 years now, and actually in our last conversation, Tyler, it was just about to be approved. and our last conversation
Yeah,
was
that-
like 1.5 years ago.
I know.
But I don't know, man. Maybe if you have some contacts on FDA, they will clarify us a little better because
Maybe.
I don't know if it's on the company side or if it's on the FDA side.
Yeah.
Well,
Since you guys have been working with these customized implants for much longer than anybody in the U.S. has, right? Anybody that's placed them in the U.S. have done it on sort of an experimental, provisionary basis. You know, we talk a lot about the back end of zygos and you know, something about, and not just zygos, but implants in general, with everything exploding, is that, you know, we can get implants to torque out, we can even get them to integrate, and then we can screw in teeth, and we're not actually going to see the consequences of overlooking certain things for years, right? It might be 5 years before you find out that something wasn't really done properly to begin with. So what do some of these long-term follow-ups of these customized implants look like? How long have they been in function? What sort of complications are we seeing? And ultimately, how do we undo it if something has gone wrong?
Yeah.
How easy are these to remove? What do rehabs for customized implants look like if you've had the opportunity to see that?
That's a great question because we started with the concept as soon as it appeared in 2017, and but we have to understand that the implants that we were placing in 2017 are way different from the implants that we are placing now in 2024. The design is different. A lot of things have changed. The micro implants, micro screws are different. And some anatomical places that we are placing the screws are also different. So we had all this journey with the company, you know, improving the things that we were seeing that could be improved. So it's the last version of the implant is from 2022. So when we compare, you know, to talk about follow-ups, we have to talk about the same object. It's a bit unfair to compare the different kind of designs, you know. But the last design is from 2022. I can tell you that the ones that I did in 2017, I have a 100% success rate. I never removed any, and they never failed. The most common complication is the exposure, which is also the most common complication of the zygo, is also the exposure.
Yeah.
And they actually expose in the same area, you know. They always expose in the buccal arm, the arm that goes along the crest, you know, that goes and turns around the crest, the same as with zygos. I would say that the percentage of exposure is quite similar. At least it is what I see in my zygo cases. You know, I was having some exposures here and there. The more vertically atrophic was the case, the more likely I was having this. And so my success rate as of today, and as far as I know, is 100% because they are all in function and functioning well. And I know about some fractures. I have seen 2 in the older designs, and the problem of those fractures was almost, I would say that all the fractures that I know about was a passivity problem. So it was
on the bone.
Yes, they were not. It was a problem with the placement, not a problem with the implant itself, so to say. And that's why they are segmented now. Because can you imagine how difficult it is to place such a big structure? It's like a butterfly, you know, from zygo to zygo. We had to place it at once. So imagine you have to place one side first and then place the other. It was very difficult to place the first ones. Now it's way easier, and it's the passivity that you are able to achieve is way easier to achieve. And yes, it's like we spoke, it's a minimal invasive surgery, fix the teeth, and the patients love it. Most of the times we do it, I know this may sound strange, but we do it with local anesthesia. And we are having great success on this, and we are receiving patients from all around the world. I've treated Australian patients, I've treated US patients, European patients, and typically the kind of patient that that has lost implant treatments before, or that heard so many times your case is not doable, that once they knew that this was available, you know, they came and they fly here and they got fixed it in the same day. And I also don't think it's fair, you know, I don't want to put this bad image on the zygos, because I don't think that way, you know. I think zygomatic implants are the second best solution for this type of cases. And I also used them before. I think that they have helped enormous amount of people that were completely hopeless. I think that the zygomatic surgery is one of the most beautiful zygomatic surgeries that you can do. It's very exciting. It's nice to do. Doing it right, it's beautiful to do it right, the right way. But as I said, for us, it's just a bit too destructive, and we have other options. But I totally understand in countries where this is not available, you know, the need to go and to use zygomatic implants, because you have to solve the cases somehow, and that's what you have, that's what you use. But yeah, that's our perspective. Since we started with this, I don't see us turning back. At least I will need to see many complications which I haven't seen yet with these implants.
And is it routine as well with relation to the exposure that you're seeing in that issue, in that position that you're also seeing it with zygos too? Are you guys doing buccal fat pads and multi-layer closure to try to insulate against that too?
That's a great question. We were talking before about fundamentals, and this is a fundamentals question, because the buccal fat pad, guys, people need to put this in the mind. Once you use it, it's gone. Poof. Yeah. It's gone. It's not going to appear anymore. Then the patients look like this, asymmetric, you know, if you only use on one side. And if you have a problem, if you lose a zygo and you need to close a communication later on, you have no buccal fat pad anymore. So we avoid using the buccal fat pad, you know, as the devil avoids the cross. The first option that we always go for is for a rotated pedicle flap. Yeah. You can get a huge coverage well, depends on the palate, depends on the patient, but most of the times you can suture a 2 centimeter hole in the crest, a communication with the sinus with the rotated pedicle flap. And that's how I think we should go. Again, for the same exact reason, for fundamentals, for principles, for going for something that is reversible first, right? And I do this on the palatal side. I know it will grow back, and I still have the buccal fat pad if things go south and if I still need to go there in the future.
Right. So we can talk. Can we talk a little bit too about the rotated pedicle flap? So can we explain what that is, what your general approach is for that, and for people that aren't doing zygos or whatever the case may be, if they see an oral-enteral communication or there's deficient tissue, how can they utilize that?
It's the easiest thing in the world. Imagine you have your flap wide open, right, on the buccal and on the palatal side, and you have the bone totally exposed on the maxilla. You look at the palatal tissue in one of the sides, you grab it, and you see how thick that is, right? You see the thickness, the full thickness of that palatal tissue. If you cut that in half, you will separate. In one side, you will have the mucosa. In the other side, you will have all connective tissue. And fat, you also see fat. That part that you separated, it's almost done. You just need to cut on the bottom to release it, right? Does this make sense? Am I explaining more or less right? So it will just stay attached on the posterior part for irrigation, right? Because all the rest, I will send you some.
Yes, we'll put that in this.
I have those slides, so I will send you these pictures. Yes. But it's so easy. It's just separate the palate in half, and then you cut the borders, so you have it mobile, just attached on distal. And then you rotate it over your defect. You suture it either to the bone or to the buccal tissue with a mattress or something to keep it stable. And then you continue to do your thing naturally. You close naturally. Everything is normal. It's the easiest thing to do.
Yeah, no, that's a great hack. I've had my first oral-enteral communication after like an indirect sinus lift, and I remembered about this, and I had not actually used it before, and I was like, oh man, okay, let's seat the patient, and then I'm going to be in my office for a second, and I'm looking up YouTube videos. I'm like, all right, exactly how do I do this again? And it really isn't bad, and it solved the problem like it was nothing. I think that's one of those fundamental toolkits that you definitely want to have for whenever you have those complications, or to prevent them if you have a deficiency.
The trick is there is only one trick, which is you have to you start with your blade, separating the two halves where the defect is. Because you have to go way more anterior, so you have tissue to
Right.
rotate posterior, right?
Yeah.
So you have
yeah.
to start next to the defect or just slightly distal to the defect, but you have to extend a lot, anteriorly,
Anterior.
because
Yeah.
you need
So you
You
can
need to
swing.
wrap around.
so you
yeah.
can swing it. Yeah.
Yeah.
And that's
Yeah, that makes
the only thing. But how did it
I-
turn out? Well.
Oh,
right?
beautifully. Beautifully. Very well.
You see?
Very well. It healed over, and then I just had to figure out what I was going to do after that.
Mhm.
But yeah.
Now,
one thing that
sorry to interrupt. For example, it's interesting you ask this. Now, this is in our lecture. This is on the master course.
Good.
Step
yeah,
by
that's
step,
great.
how to do this technique.
Good.
Because, again, doctors ask for it, and it's such a precious move to solve so many complications.
It is. No, what I was going to say is, so let's say you go to do that, and every so often I'll see someone actually has a very thin palatal tissue. I mean, it can happen from time to time. What happens if you're just not really able to split the difference on that? You're not able to get the connective tissue out. Is there a full thickness version of this that you can do that's going to be a bitch to heal? Or like, what do you do if the tissue is too thin there?
You go to the tuber. That's the second best friend.
Sure.
You go to the
Okay.
tuber. Yeah.
Okay.
The only disadvantage on going to the tuber is that you have a flap that you have a free flap, right? It's not
Mhm.
connected to any.
It's transplanted now.
It's a transplant. No.
Mhm.
Yeah.
So I did many of them in the beginning when I was afraid of the greater palatine. I was going to
Yeah,
the tuber, and I started having a few necroses here and there. And I was like, okay, maybe I should lose the fear of the greater palatine. That's another thing doctors starting now have to understand, that the bleeding from the greater palatine may look like a lot to you, but from a surgeon perspective, that's peanuts. That's nothing. That's not a serious bleeding, And I will tell you this story very quickly. In the last boot camp, we had a student that with the flap elevator, when he was raising the flap on the tuberosity, he was making so much strength with the arm that it slipped from the crest and it cut the greater palatine at the origin, And the guy was a bit in panic, and his colleague was also in panic, and we were like trying to be very pedagogical with the situation. He's like, okay, guys,
Yeah.
this is a bit of bleeding, but it's not that serious, okay? It's not that much. If you see a serious bleeding in maxillofacial surgery, if you see a LeFor1 or a LeFor2, man,
Yeah.
I have dealt with those kinds of bleedings. This is not one of those, This is anesthesia, compression. Most of the times, in 5 minutes, it's completely gone if you do the right maneuvers.
I think we
So-
chatted too I posted something a couple weeks ago about how, maybe not life-saving, but a great tool to have in your toolkit is just some sort of electrocutter unit, right? If you can get a Bovie,
The Bovie, man, everyone should have
Yeah.
a Bovie.
and
It's
if
so
you're
simple to
unfamiliar,
use.
you can use Bovie pens. There's disposable Bovie pens for like anywhere from like $10 to $20 a piece. You can even
Yep.
get Bovie pens with exchangeable tips that are around $100, and you can just
Yep.
get different tips. But just spending that $100 to have something that can cauterize that bleed in your operatory is
a simple monopolar one is more than enough, or even the pen.
Yeah, and if you have questions about which one I've used before, you can reach out to me. I'm happy to answer them. But there'll be just one less thing that you need to worry about, because if you do have a bleed that doesn't, you can't get it to stop with compression or with epinephrine or whatever you have, a Bovie will definitely solve that issue for you.
Yeah. And losing, and it's actually quite pedagogical, to hit the greater palatine 1 time or 2 times or 3 times, because you start to not worry so much when these things happen. And sometimes on the taking a graft from the palate, a connective tissue graft, or even a free gingival graft, sometimes it happens, starts squirting, but you keep your cool, you do what you are supposed to do, and it will always stop. As a friend of mine told me many years ago, a maxillofacial surgeon, when I was in the residency, all bleeding eventually stops.
What's coming?
Eventually, it always stops.
It's
So-
self-resolving.
It's
the way that I
self-resolving.
like to handle, because I've gotten, especially doing pterygoids, if you're back in the pterygoid region and you reflect a lot, sometimes you'll get a little bit of bleeding from that greater palatine coming from under the flap. And the way I like to solve that is, one, I don't want to sit there and spend 10, 20 minutes of my surgery just compressing it. I just grab my hemostat, clamp the tissue right there, and it goes away. And I keep working with the hemostat clamp there. And, when
you remove it, it stopped.
Yep. And by the,
it's done.
15 minutes later, you've been doing something else that, you need, take the hemostat out and you're good to go. And that way you're not sitting there, wasting your precious surgical time where the patient's under anesthesia. You can think, if you have an anesthesiologist there, I mean, you're paying a good couple $100 for every 15 minutes. Maybe not quite that much, but that time is critical. And
exactly. That's another. Sorry to interrupt. That's another lecture we introduced in the boot camp in Brazil. First day is how to deal with heavy bleeding. For example, it's another thing that we were changing and improving because we saw people panic a bit, and I understand. I also panicked in my first ones, but it's really not something that big. It's big for dentists. It's not big when you are used to other kinds of bleedings. I remember in the Netherlands, I saw a guy that was in a fight with someone that had an axe. Can you imagine fighting someone with an axe? And the guy had a major cut. This was the most serious thing I saw in my life, and still solvable.
Yeah. One thing I wanted to mention that I forgot to say before, and it's kind of a question for you too, Bernardo. When you're doing rotated pedicle flaps, another pro, in my understanding, is compared to a buccal fat pad is a lot of times that connective tissue regenerates. So you're able to not right away, but once it heals up, especially in, I see a lot of patients that have palatal tissue that it's thick. It's really thick.
Yep.
In a lot of surgeries,
Sometimes it's too much.
It's too much and you need to thin it out. But if you're able to, instead of thinning it, you can use that to wrap around the implant to preserve keratinized tissue. That's always a solution to come back to again to use if you need to down the line.
Yeah, exactly. It's I think I mentioned this before. That's one of the pros of using the palatal tissue is it regenerates. Not fully. Actually, a friend of mine did a study exactly on how many cubic millimeters it regenerates after 1 year. And it was, he found out that it was not fully, but it was about 85-90%, if I remember correctly. So it's almost everything. And 1 year later you have it there again. So it's like an infinite pool of good tissue for you, that keeps coming back, keeps spawning. Is this the right word? Like the Pokemons when they spawn?
Spawning.
Okay, then you edit this. Respawn.
It's a renewable energy source. Oh no, that's staying in.
Respawn. I like that. It respawns.
Good.
Connective tissue respawns.
Yes.
Yes, absolutely.
That's good.
Well, hey Bernardo, we went over so much in this episode, and I've actually, if you're watching this on YouTube, you've probably watched Bernardo's sun setting behind him throughout the episode. So,
that's true.
We really appreciate all of your time on this episode, and this will be one that gets cut up into a few episodes because it's been a journey throughout. But, we really appreciate all of your time, and I think that anybody who's looking to up their full arch game and get, prosthetics that have no cantilever and are looking for solutions to bleeds and looking for ways that they can take on more patients without going through larger approaches like zygomatic implants and stuff, it is critical to check out the Full Arch Club. Additionally, I don't think that you're able to get in. I get questions too, like, hey, how do I get into Bernardo's WhatsApp group? And it's go to the master course, go to the boot camp, and you'll get access to a lot of clinicians, some of the best clinicians in the world, who are able to answer some of these questions that you have immediately. I think everybody in that group is very transparent with, I'm in a surgery, I had this issue, what do you recommend? And you get a lot of responses from wonderful clinicians throughout the world just by having access to that group. So I think it's a wonderful CE to take if you're looking to get into, more advanced cases. And again, we really appreciate your time today. You can follow Bernardo. What's your Instagram, Bernardo, just so people can look through your stuff and see the Full Arch Club?
So we have two Instagrams for you, Bernardo N. Sousa, which is mine, and the Full Arch Club Instagram as well. And as we were talking in off before this goes to air, we are at the moment preparing courses that have never been done until today, not only to help you become the best surgeon possible, but also that you become the best person operating. I will not disclose more information now, but it will be something radically different from what has been done until now. We are also going to launch soft tissue only stuff, because a lot of doctors are asking, and they ask on the group and on the WhatsApp group as well. So we are preparing what I believe to be the most complete full arch soft tissue course for doctors, where you learn all the techniques that you need in the full arch game, with a bonus, I think I can say that it also involves soft tissue, but it stresses your nerves. So we are. I will not disclose everything now, but
the more you tell me, the more questions I have. It's not.
I think I'm getting the gist.
Yeah. So it's going to be fun. So yeah, keep tuned, and also on the website, because if a course exists, better than asking me or the manager or anyone is to see on the website. If it exists, it's there. So fullarchclub.com. When I have to know where I have to fly for a course or something, I go to my website, because I don't know. That's your memory. So it's my calendar.
Well, hey, thanks so much. And again, you can always find Tyler and I at my Instagram's Dr. Soren Poppy. Tyler's is Dr. Tyler Tobert. And then you can reach both of us at the Fix Podcast Instagram. Again, if you're listening to this on Spotify or whatever platform you use, we always have these videos on YouTube as well, where you can see, all of our faces, and we try to incorporate as many panos and stuff into the videos as possible. So definitely take a look at those. And again, thank you for your time, Bernardo.
Thank you very much it's the second interview that we do. And, I feel like a bit of a dad for you too, because I saw you in the very beginning, and now two years later, it's really, honestly, it's impressive the way you two are growing, and other guys from the bootcamp as well, and your new project with the clinics. And you remember we talked about the brain. You guys have the right brain. Okay, and this is, as I said, the clinical part is the easiest to learn, but having the right brain is something difficult to teach. And if you are born with it, use it wisely. And you are born with it. And I'm really proud of the things that you are accomplishing, not only in the clinic, but also with the podcast, previously with the other one, and now with the Fixed podcast. And I think you deserve everything good that is going to happen to you, because you work hard, you are smart, and you apply your smartness into doing good things to people. So keep doing what you're doing. It's really motivating to me to have contributed, if with something, to this.
Well, hey, thanks so much, Bernardo. That means a lot coming from you, and you've always been a wonderful mentor to us, and we really appreciate it. So thanks so much, everyone, for listening, and tune in next time for the Fix Podcast.